because it is a public meeting. The recording will be posted on the advisory committee's webpage shortly after the meeting. And for everyone's reference, today's agenda can be found under the first tab in the agenda materials. And as a reminder, if you're not a member of the committee, please turn your camera off now. Vishal Chaudhry, Chief Data Officer for the Healthcare Authority, will now call the meeting to order.
Thank you, Mandy. Welcome, advisory committee members. Like Mandy mentioned, I am Vishal Chaudhry. I'm the Chief Data Officer for the Healthcare Authority. It is now 2:03, and I call the April 4th meeting of the Advisory Committee on Data Issues to order. I'm extending a warm welcome to everyone joining us today. If you can open to the agenda tab 1. Just, Mandy, I don't know who's running the slides. There we go. Just an overview of the agenda. We'll begin with the roll call, but I don't join this committee often, so I don't want to assume that everybody knows everyone. So if you could just introduce each, yourself, and when your name is called, if you let us know what's your favorite thing to do in spring. After that, we'll have 2 meeting summaries to approve, one for the November 2022 meeting and one for the February meeting. The committee did not approve the meeting minutes for the November meeting in February because it was a joint meeting with the Committee for Healthcare Providers and Carriers. Once we go through the minutes, after that, we'll hear the public comments. After that, John Bartholomew and Tom Nash will present on Washington hospital costs, followed by Jean Marie about the Primary Care Advisory Committee, and then Michael Bailett will provide a presentation on the benchmark, with Ross McCool providing updates for the next 2023 year benchmark data call. And finally, Amy Kinner from OnPoint will present on the study of cost drivers in Washington. It is a full agenda, but I encourage committee members to ask questions, provide feedback, facilitate our discussion and recommendations to the board. I really want to thank you all for your time and efforts in support of this work. Turning back over to Mandy Weeks-Green to go through roll call. Also noting that my friend Mandy Stair is here as well from OFM. So if I just say Mandy, I'm referring to Mandy Weeks-Green. Mandy Stair, when I call on you, if I need to, I will be sure to mention your full name. Just so
Thank you.
avoid any confusion. All right, and please, as you go through the roll call, please introduce yourself and remember to let us know what's your favorite thing to do in spring.
Thank you. Good afternoon, committee members. I will call on members by their first name in the order listed on the agenda, which is alphabetical order by last name. When I call your name, please unmute your microphone and let us know what's your favorite thing to do in spring, and please mute your microphone again. Megan, Amanda.
Hello, Amanda Avalos. I like to start vegetable gardens in spring.
Me too. Allison?
Yeah, hi, Allison Bailey. Oh gosh, I don't know. Pick weeds.
Thank you. Jonathan?
Jonathan Bennett. I'd say probably hiking, getting out and enjoying hopefully better weather.
Excellent. Thank you. Bruce?
Hi there, Bruce Brazier. I'm looking forward to sitting on our deck reading a good book in the sun.
Good. Jason? Jason? Chandra? Chandra? Leah? Leah? Lee Chow?
Hi, I'm Lee Charlie. I'm the Chief Actuary with OIC, and my favorite thing to do in spring is go for a walk when the weather is good.
Excellent. Thank you, Lee Chow. David? David? Anna?
Hi, everyone. This is Anna. I like to volunteer for beach cleanup to get our SoCal beaches ready for the summer.
Nice. That's wonderful. Hunter?
Hi, I'm here. And what I like to do in spring is, yeah, hit the trails and go hiking. Definitely the season for
Sounds like you have a new companion.
it.
Mark?
Good afternoon, everyone. Mark Pregler, and I'm definitely in the hiking camp.
Excellent. I am sensing a meetup. Russ?
Hi, good afternoon. I am Russ Schust, and for springtime, it's similar to Allison, and that is yard work, picking weeds, getting things looking pretty.
Excellent. Thank you. Julie? Julie? And Mandy?
Hi, this is Mandy Starr from OFM, and I'm in the gardening camp.
That's a good camp to be in. Thank you, everyone. I will turn it back to Vishal, who will facilitate review of the meeting summaries and the public comments.
Thank you, Mandy. Yes, all of you guys who talked about the sun, I'm with you. I could use a little bit of that. We live in Camas, and believe it or not, overnight there was a little bit of snow. It's April 4th, like, come on. You know, but on to happier things. Meeting minutes. So if you join me in turning to the second tab in the committee book, the recording of the last two meetings is posted on our webpage. For the purpose of today's meeting, we will use the consensus process for a vote on the approval of the two meeting summaries. First, the November meeting summary. Is there any discussion of November meeting summary or proposed changes? Hearing none, I propose that minutes are accepted without change. Any discussion of that proposal?
I approve it if you need an approval.
All in favor, say aye.
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 Any opposed? All right, hearing none, we will consider that motion approved. Moving to the February meeting summary. I propose that the meeting minutes are accepted without change. Any discussion? If not, all in favor, please say aye.
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 Any opposed? Hearing none, we'll consider the motion approved. Thank you very much. You guys make it painless. I appreciate it. Thank you. Next, I would like to invite and welcome any public comments. Written public comments received since our last meeting can be found under the third tab in the committee book. At this point, we allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide public comments. If you've not signed up and would like to provide public comment, please raise your hand. I see your hand, Katerina. Give me 1 second while I go through this. And then Mandy will call on you after we hear from individuals who've signed up. When you're called upon, please state your name and affiliation. And if any, before speaking, if you're unable to raise your hand in Zoom, we'll provide an opportunity after for additional comments. Again, please don't place or raise your hand more than once. It helps to ensure that everybody has a chance to speak. You're also welcome to provide comments in writing. Please remember that this is the time for public comments. Any Q&A sessions during the meeting are times for the Advisory Committee on Data Issue members to ask questions. Turning it over to Mandy, could you please start with the names of individuals, if any, who have signed up to provide comment?
Sorry about that. No individual signed up to provide public comments so far, Vishal. I will happy to call on anybody who's raised their hands, and it sounds like you had identified someone who had raised their hands. Katerina?
Great, yeah, thank you for the opportunity to provide comment. I'm Katerina Lamar at the Washington State Hospital Association. After reviewing the materials, we have sort of one general comment for your consideration, which is that we think that it's important to take into consideration how the two analyses on costs, the one by OnPoint and the one by the state's consultants, John Bartholomew and Tom Nash, should relate to each other. The Bartholomew Nash cost analysis demonstrates that case mix, input price, and wage rates are key factors or drivers of cost, but those factors don't appear to be taken into account in the OnPoint analysis, at least on year-to-year changes in hospital payment. Really, to us, it seems like the analyses are being done in silos, and we think the approach should be a little bit more uniform to ensure that there's consistency between findings. We also generally think that creating a more continuous standardization, standardized adjustments by CMI, Medicare wage index, and teaching status would better facilitate comparisons between states and hospitals rather than comparing them independently. In addition, we also note that benchmark work shows an analysis for hospitals and providers only taking into account the year-to-year change in inpatient and outpatient rates. And what we didn't see is a discussion of changes in case mix between the years or different treatment for hospitals depending on whether they are low or high cost compared to their peers. And we think that these additional analyses on the hospital rate increases would be important information for the board as they consider entities' rates of increase, since these factors are known to impact hospital costs and payment. So we would really appreciate a more technical discussion within this group on the appropriate use for these analytical exercises and a better understanding from the board on how they'll be used, especially in light of the recent efforts to tie more accountability to failure to meet the benchmark goals. Thanks again for providing, or for the opportunity, to provide comment, and we look forward to the discussion today.
Thank you, Katerina. I'm looking to see if I see anybody else's hands raised. I don't. Is there anybody who's unable to utilize the raise hand feature that would like to provide public comments, such as someone being on the phone?
Andy, I'm not hearing.
I'm not hearing anybody. I will turn it back over to you, Vishal.
Thank you. Thank you for providing your public comments. At this point, we will close the public comments part of the meeting and move to our first presentation. John and Tom, as mentioned, will present on Washington Hospital cost, price, and profit analysis. Welcome to the Committee on Data Issues, John and Tom. I'll hand this over to you.
Thank you very much for having us, and greetings, folks. I'm happy to be back presenting some of the updates on this project since our last meeting in front of the Advisory Committee on Data Issues. I want to Tom is also available for questions, and I will appreciate someone to advance the slide deck. That would be great for me. Yeah, I want to point out these two project goals because I think they're important. They're important, especially in light of the written comments from the Washington State Hospital Association, that we're undertaking this work to look at the Washington hospital industry and see how it compares on a national level. Each state is a little bit different. Tom and I do work in some other states, and we do have some insights from that work as well. But I think it's important to make sure we're focused on our project goals, which are, how does the Washington hospital industry look compared to the nation on costs and margins and profits? And can we identify Washington hospital outliers on cost and margins / profits. So this work is ultimately to peel the layers of the onion back of the hospital industry, create similar looking peer groups of hospitals to Washington hospitals, and then look at costs, margins, profits, and some other metrics, and give that information to the board, to the data advisory committee, and also the healthcare cost transparency board. So these questions are important, but let's go to the next slide, and I'll do a little refresh. Starting back in May of 2022, Tom and I started presenting to both the Advisory Committee on Data Issues and also the Healthcare Cost Transparency Board. This process of analyzing hospitals' financials. So that first level analysis that we spent basically from May through September working on with you folks was kind of a high level. It had its faults, which we'll get to in a minute, but it was a high level review looking at self-reported hospital data from the Medicare cost report and summarizing some of those pieces of information in that cost report down to something we call simply price per patient, cost per patient, and profit per patient. And this is all information that's used from Medicare cost report worksheets, actual cells, and the formulas for these metrics are available to anyone. They're very open source information. And the idea in looking at this information over time is that we want to observe trends by grouping hospitals into similar looking groups. Similar looking groups like, are they for-profit or not-for-profit? Rural versus urban. Are they teaching or not? Are they an independent hospital, or are they part of a hospital system? This analysis, and we'll refer to it a few times today, this first level analysis is very similar to work that's happening elsewhere in the country. In fact, the National Academy of State Health Policy has introduced a hospital cost tool. And that cost tool has very similar metrics in addition to a few others that we use from this first level analysis. And that hospital cost tool is funded by Arnold Ventures. It's a highly used and highly scrutinized tool, open to the public, and can be downloaded. Certain pieces of information can be downloaded. Our first level analysis that we've presented so far to this committee, as well as the Cost Transparency Board, is a similar methodology, very similar theme. Just a high level review and looking for outliers. So trying to normalize all the variation of a hospital to a hospital, and comparing a hospital to a hospital, and trying to get at, well, what other reasons might there be in causing a difference, and especially when we identify outliers. So from our first level analysis, we had some summary findings. So let's go to that next slide. And that's in the summary findings we grouped into high price and normal price, or not high price. And then from there, we looked at costs, whether they were high cost or normal cost. And then from there, we looked at profit. And what we found, looking at Washington hospitals with greater than 25 beds, is there were some of each that were high cost, high price, and also high profit. But also of note are some of the not high price or normal price that had high cost. Some, in fact, had high profit, and some of the normal cost hospitals had high profit, and some of the normal priced low-cost hospitals, there was just one that had a high profit trigger outlier. We acknowledged that this first level analysis was really just a first cut, and we're happy to be back after working on some methodology enhancements to do this second level analysis. So let's quickly refresh our memories on the next slide of some of those shortcomings of this first level analysis. And they, we acknowledged in our last presentation, I believe that was in September, that a deeper dive would be important to better understand what's driving the variation of some Washington hospitals in price, cost, and profit from the national median. For a fair and accurate comparison, we need to look at other measures, case mix, service intensity measures, a hospital's level of teaching, their payer mix is also has plenty of insights there, and other financial measures that would make it better to compare hospitals to hospital, a better apples to apples type comparison. The goal would be to adjust for these measures or group these measures, and so that differences, so that we can measure the variation in cost and isolate it to business decisions that a hospital makes. And there could be other factors still that could be causing that variation. But this is, to me, this is a process that we encourage Washington Healthcare Authority to travel down this road and begin to understand what might be driving some of the cost variation, some of the profit variation. And therefore, we've been engaged to review or do this second level analysis. And we're happy to share some of the methodology enhancements that we'll be doing on this second level analysis. Let me go to the next slide and just talk about process. Now, this is a pretty quick presentation, Vishal and Mandy. So I hope there's a whole bunch of discussion. I would love to engage with Katerina on some of her points if they are pertinent to this hospital second level analysis, or Jonathan, or if Albert or others that were part of this process. But what we did is we met with Healthcare Authority staff and convened a series of meetings. We pulled some subject matter experts from this committee. In fact, we used Albert Frolling's time from the Washington State Hospital Association. I hope it's okay to name names. But Hunter Plumer from Health Trends and Julie Sylvester from University of Washington Medicine all participated in these meetings with Tom and myself and lots of folks from the Healthcare Authority staff. We met 4 times between January and February and came up with a process developing kind of what we might want to look at in better enhancing that first level analysis. We didn't agree on everything. As you can see, there's a written letter from Washington State Hospital Association. But I do feel like we are much closer to agreeing on this level of analysis, that it is needed, and that there's a few issues of differences of opinion, and I'd be happy to address any of those questions after we get through the analysis. It's really just two more slides, 2 or 3 more slides, and we'll get through this methodology. So let's start with the next slide. So we wanted to group these enhancements into 2 types. One are actual calculation adjustments, and another is a kind of a way to group hospitals to enhance the peer group analysis. Recall from the first level analysis, the peer grouping was just based on bed size. So we took a hospital's bed size using ranges, 26 to 100 beds, 101 to 300 beds, et cetera, and compared those metrics summarized in that one slide around first level analysis, cost, price, and profit, and compared Washington hospitals to their national peers based just solely on bed size. We also did some rankings. How does Washington compare nationally? And some of those costs were adjusted. So we received feedback on how we can better adjust costs so that we can better compare Washington hospitals to the rest of the nation, taking into account variation of costs from labor to services. And then enhancing the groupings and beyond just bed size. There's, of course, a lot of variation in hospitals beyond bed size. Some hospitals have a range of teaching using a metric that's fairly common in Medicare rate analysis, this resident to bed ratio. There's also other groupings we use that capture service intensity, and also grouping using the Medicare inpatient case mix index to control for that measures acuity on the Medicare inpatient side. And then an additional piece of analysis that is added on from the first level and the second level is a Washington hospital margin analysis. On the margin analysis, we're going to do a complete review of Washington hospitals, looking at both profits and margins as compared to the nation, and identify outliers. One thing we will all agree on is that we don't need to risk adjust for acuity differences or teaching differences, the margins or profits. This is a measure that we don't need to adjust for inflation differences between parts of the country or teaching intensity level or intensity levels. So let's go to the next slide. So the adjustment to cost in the first level analysis, when we ranked all the states, all the hospitals within the states and ranked the states, we used a very, it's called C2ER. It's an inflation adjuster that we applied to all of the hospital's costs. And by working with our work group and the subject matter experts, we enhanced this to adjust costs two ways. Using labor costs of a hospital, we are going to adjust those costs using the labor wage index. This comes from CMS wage index files. And the rest of the costs that come out of the Medicare cost report will be adjusting for inflation using C2ER. That was one of the comments made in the letter. I hope we get a chance to discuss that today. So we'll be calculating a salary percentage that we're going to apply the labor wage index to using Medicare cost report information. So I was told today's kind of a methodology meeting, so we're going deep into the methodology. I don't have any output yet to share, but we hope to be coming back with output soon. So that's the adjustment to cost. Before we adjusted for inflation at the state level, all hospitals, Washington did kind of score pretty high in those rankings. A better adjustment was to look at labor wage differences across the country. So we're going to, instead of just using one inflation measure and adjusting it to all of the hospital costs, we're going to tease out the salary percentage of hospital costs, apply the labor wage index information to that, and then the rest of the service costs will be adjusted using an inflation measure to incorporate price differences across the country. The next slide is on the groupings. So this is an enhancement from just using bed size. And what we're doing is we're creating 3 extra measures that we will group like hospitals too. One is the teaching intensity measure. So this is looking at physician resident to bed ratios. And when we do that, we have a nice number that we can group hospitals that have similar ratios to. Also a service intensity measure. This calculates intensive care cost differences that one hospital might have versus another. Maybe they're the same bed size, but one hospital might not have any intensive care units and another might have several. One might have just a basic intensive care unit and another hospital might have a burn unit, a neonatal intensive care unit, and other beds for other types of intensity, for intensive needs. So we've created a measure that looks at the different types of service intensity costs and grouped hospitals using that measure. And then we have Medicare's case mix index. This is commonly used to look at acuity differences that a hospital might have on its patient lists. There are some shortcomings with the Medicare case mix index. It is only based on Medicare, and it's only based on inpatient stays. So it's a subset of the payer groups. So it doesn't have any Medicaid information or commercial or other payer information. But then it's also a subset of Medicare business. It's only based on inpatient. Other measures we will draw in as we're identifying outliers and looking for the reasons a hospital may be an outlier is we'll review the payer mix, which is simply just looking at a hospital's government payer mix versus others, commercial and other payers, and take into account differences there as well. That is essentially the enhancements we've come up with for this second level review. We're looking forward to getting started. And I think the remainder of the time, Vishal, we can see if there's any questions or commentary anyone has.
Thank you, John. Tom, before we open up for questions from the advisory committee members, I'm wondering if you had any thoughts to share, or do we just open it up?
No, John covered it very well. I would say that rather than terming these inflation factors, it's probably more appropriate as cost of doing business factors. Other than that, yeah. So yeah, please, by all means, let's see if there are any questions.
Thank you. Thank you, John and Tom. At this point, opening it up to the advisory committee members for questions, comments, suggestions to the consultants on their approach.
Yeah, this is Jonathan from the Hospital Association. So, Tom and John, I appreciate your guys' willingness to expand and explore these different factors because they do play such an important part in telling the story, especially when you're looking at it from a national perspective. I'm curious, because our preference would be, it's important to be looking at these factors, and independently helps kind of paint the picture of how they impact the overall story. And so I get that aspect of it in telling the audience how each of these pieces move together. But as Katarina mentioned in the public comment section, I think it's important to be looking at these from a continuous standpoint. It's not uncommon. I mean, it's been used in the nation throughout many, many years of looking at wage index, case mix index, and adding those all within the overall adjusters. So it's one thing to be looking at them independently, but I think it tells the ultimate story when you compound those together, and that's going to help ultimately tell the bigger picture. So we would strongly encourage you to take into consideration the continuous adjustments, but we do appreciate you exploring and working with the subgroup in exploring some of these differences that may have a story to be told here in Washington State.
Thanks, Jonathan. We appreciate that. Yes, yes, we're aware that oftentimes it is a common practice to adjust for case mix index. We had a decision to make. Wage index was an easy one to adjust for wage index. This is the adjustments based on actual hourly salary information from the hospitals. So it's a pretty tight adjustment to make, and it makes sense so that we can kind of normalize out the cost of labor as being a factor in variance between hospitals. Case mix index gets a little more sticky. We've taken a look at this. We see very, very, very little correlation between case mix and net patient revenue per adjusted discharge overall. So in other words, it doesn't explain much of the difference. And when it doesn't explain much of the difference, we're a little hesitant to make an adjustment of all revenue for case mix. However, we do feel it's an extremely important factor in why one hospital may be more costly than another. And therefore, that's why it is one of the peer benchmarking factors that we will be using. We will only be comparing hospitals to other hospitals that have similar case mix. Same is true with the teaching intensity. We'd only be comparing hospitals with similar teaching intensity and also hospitals with similar service intensity. Again, so while you have a decision to make whether you adjust the numbers or adjust your peer groups, we chose to adjust the peer groups simply because we believe adjusting the numbers may be adjusting an entire number when only a part of that number is actually impacted by the case mix or whatever factor we're looking at. So hopefully that explains a little bit of our thought process. And welcome any more feedback you have.
Yeah, I think my take would be to do the analysis and help kind of paint the picture. It's one thing to talk about it, but it's another once you kind of get into the nuts and bolts of it.
Mm-hmm.
And I think you can actually glean a lot of that information. So we would encourage you to do the analysis, work with the subgroup to continue the conversation. And then ultimately, as the analysis is being performed, I think you can get to more of where you want to land. But talking about the approach, I agree, is important. But actually doing this to be able to show the picture because of what's at stake here, I think is going to be prudent.
I completely agree and appreciate your comments. Sure. I think that's the reason why I wanted to make sure I highlighted the questions at the beginning of the presentation is important, that in identifying outliers. Well, let's see. I don't know how much. I don't want to take too much time. But I guess briefly, we want to identify kind of outliers, grouping similar hospitals across the country with as little adjustment as necessary, so that we're not masking the information. When we're making adjustment after adjustment to a cost or to a price measure, I feel like we're just stepwise moving away from what a consumer is actually paying, whether it's a payer or a patient. We can do both, and that would be up to the healthcare authority and directing us. We're happy to do both, but I think our first step of this second level will be to make that one cost adjustment and then group the hospitals to identify the outliers. Then we can further make adjustments. We can look at other considerations. Maybe a certain hospital is an outlier because of their payer mix or whatnot. And there's even other measures that we didn't get into that we can look at as well. So I'm really excited about this next level of work, where it takes us, and sharing the findings.
Thank you, John. Thank you, Jonathan. Other committee members, thoughts, comments, ideas, questions? All right. Well, thank you again, John and Tom, for this great information. We appreciate your partnership and your help with this work. And thank you to the subgroup for participating with John and Tom in helping shape this next level of analysis. Next, Jean Marie Dreyer will provide us information from the Primary Care Advisory Committee. Welcome to the Advisory Committee on Data Issues, Jean Marie. I'll hand it over to you.
Thank you very much, Vishal. Good afternoon, everybody. My name is Jean Marie Dreyer. I'm a Senior Health Policy Analyst with the Healthcare Authority. Some of you may know me because I know several of you are here and have been on the Primary Care Committee. So Mandy and Sharon Iloranta, I saw you here. So, and Shane, who helped facilitate last week. Folks can keep me on my toes. And if I say anything out of line, let me know. I hopefully won't. For those of you who are not from the Primary Care Committee, just to familiarize you a bit with some of the work, this all started by a legislative statute, and that stipulated several recommendations that our Primary Care Committee have to mull over and come up with some solutions for. And right now, this slide here is just giving you an example that we have accomplished a recommendation that has been approved by the Healthcare Cost Transparency Board. It came through the Providers and Carriers Group as well. And I believe you guys got a chance to look at it too. So it funneled through all the subcommittees up to the board who gave their final approval. So yay, that was a great achievement. And then now we're on recommendation number 2, which I put in yellow here. I was debating putting it in red, but I thought, oh, red-green color blindness, and one of my best friends. I'm like, oh, maybe I'll change that. Anyway, so hence the yellow. Enjoy. That's just to say that we're in the process of looking at this recommendation, and that's the primary topic that I'm here to talk to you about today, is the assessment of claims-based spending and really getting into the code level data, specifically on the service level. We've talked through providers and the facilities. I'm not really going to touch on that today. If you want more information on that, I'm happy to send it to the committee to look at. But we really want your expertise on and feedback on the codes themselves and how you think acquiring them feasibility-wise and interpreting them will work going forward with an actual implementation plan to track claims-based spending. And then you can see here, there are the other 2 recommendations that we have not yet gotten to, but will also take up several meetings worth of our time. Mainly non-claims-based spending, which is an area that not too many states have delved into yet, but we want to be the pioneers on that. And Oregon has done some work there, but we will build off that as well. And then eventually we'll also touch on some of the barriers to access and use of primary care data, which I highly anticipate will come back your way again as well, since you are the data experts. So now, next slide, if we can turn to, this is kind of our foundational, how are we connecting together what counts as primary care for tracking purposes? And so we're really looking at it from 3 different lenses. There's the provider lens that I mentioned and the facility lens that we've gone through, the group has gone through already. And we have some base level, who we think the provider should be, what we think the facility should be. But now we're on that the actual individual codes, service codes, which is quite a lengthy process. And so we really want all 3 of these to intersect. And already there have been some questions regarding specifically, other states don't necessarily take into consideration the where. So if we're the first to do that, how are we really going to reconcile that? You have primary care clinics that might be on site at hospitals. How do you not blur the lines? How is that getting tagged? So there are some obstacles there. But the what specifically, we had a set of about 200 some odd codes that we're starting to wade through, and we got through a good chunk of them last week. I will be sending out the full set of those that we've looked at and made some decisions upon for you to review via email. I didn't want to bombard this group with that now. I just wanted to kind of do the high level overview and then lead into that to get your feedback. So, but any questions on this initial intersection, the view that we're looking at before I move on? All right, if not, next slide, please. So we did, because we had such a high volume of codes that we had to get through for the purposes of discussion, have to set some ground rules. We are not trying to get every last thing under the sun. That's not possible. There is always going to be some concern as to, well, what if we missed this very significant code? And we tried our best to capture the most obvious, commonplace, bread and butter primary care codes possible. And that's because we really want to incentivize what is the heart of primary care when we're doing this 12% spend estimate. So with that in mind, for future data analyses, we can also identify services for consideration that might be frequently provided by certain approved provider types at approved facilities that are included in our definition that was formulated by the committee. All that is to say, all of this is pending future data analysis, right? So we have these codes, but until we actually run the analysis and then, sift through it and reflect on it, that's going to be our check on ourselves to say, did this actually meet with what we thought were the most foundational codes, and where are the cracks and where do we need to fill in? Next slide. So just a little bit, I've alluded somewhat to the process already, but to give you some, actual point by point here. Where we started, we had this large list of codes that came from a list curated by the California Healthcare Foundation that's available on the Primary Care Collaborative website. I'm also going to give you that raw list to look at after this as well. That'll be sent out via email. And then from that large list, we refined it to compare individual service codes that were used for measurement purposes across multiple states. And we're talking, 8 or so odd states, plus several healthcare organizations like Milliman. And so that was giving us a nice broad body of work to say, okay, well, what really are the most fundamental codes that are included across states? So that was our next level of refinement. And then we had HCA internal clinical staff who further refined and distilled the code set list to give their expert recommendations back to the committee for consideration. And then we solicited more feedback via email and in person or hybrid during committee meetings from individual members. So we got, some comments there about what to include, what to exclude. Maybe there were some things, there might have been discrepancies with clinical staff versus committee member opinions. And so lastly, we had our colleagues from the Center for Evidence-Based Policy, and I know Shane is on here, if any questions come up, putting you in the hot seat, helped very graciously to create a final list for us that showed the percentage prevalence of individual services across those other states, and then provided a formal recommendation in a column that came from the HCA clinical staff. So that's a lot to take in, but basically picture a spreadsheet where you have a code, the description of the code, and then you have the percent prevalence across other states. So some of those, it might be low, it might be only 8%. Sometimes all the states and organizations agreed and 100% said, yes, this code is primary care. And then finally, you have the recommendation from HCA saying, yes, include, or no, exclude. And that's what committee members voted on. So the last 3 slides, if you turn to the next slide, this is just letting you know all of the various categories. There were 27 altogether. There's a lot of codes to get through that we started talking about last week. And to the credit of the committee and large credit to our colleagues at CEBP, we actually got through 14 out of 27 categories, so a little over half. So that's really impressive, actually. And so that was really good work. But I don't know necessarily if you all want me to read through each of these, or we can just give a moment on each slide just so you can see the full set. Yes, that's great. And then the last one, or I guess that's the last, yes, there we go. And the only other piece that I would point out is I think there was maybe a typo, and this is completely my fault here, but it said home health, and this was something we missed in the initial too. It should say home visit services for one of the categories. So just to distinguish, because I know they're not the same thing. So, but we made great progress last week. I think some of the main questions that came up again were, how are we really going to reconcile those three intersections between the who, what, and where? How is that functionally going to work once we pick through the codes? And there's also been a lot of discussion of, OFM, the Office of Financial Management, put out their report on primary care spending a few years back. And they had to go through a long process to figure out what percentage of certain providers would actually count for codes. Physician assistants, for example, were only allotted 60% of their total services to actually count as primary care. Mandy can speak to that if you have a question. Mandy Starr, not Mandy Weekscreen. So just a lot to take in, but what we're really looking for when I send out these codes to you all to look at is to take a look and say, okay, if you have any familiarity with them, how hard is it going to be to access them? Are there any things that leap out in terms of things missing? But keeping in mind that overarching ground rule that we're not trying to take every last little code and make sure it's accounted for. We're really going for the core primary care services, because that's what we're trying to incentivize in measuring the spend. So it's quite the task. We appreciate your help in getting this accomplished and reviewing our work. Does anyone have any questions that I can follow up on or bring back to the committee?
Thank you, Jean Marie. Opening it up to questions from advisory committee members. Again, like Jean Marie said, questions, ideas, thoughts, guidance, concern. We have an open tent. Everything's welcome.
And if not at this time, I completely understand, because you're also going to get this large list to sift through, and I'm sure that will generate plenty of thoughts for you as well. So that's to be expected.
Yeah, I just want to reiterate one thing that Mandy, sorry, Jean Marie, you mentioned a couple times. The intent, even though the building of this list and the code set is going into a lot of detail, the intent is really still an aggregate analysis. So I think we need to keep that purpose in mind, just like the previous presentation. The detail is good for us to understand, but at the end of the day, it's a higher level aggregate analysis that the board is interested in and looking at this point anyways. And we will learn as we go. So there'll be opportunities for refinement as we go along. So.
Right. And I would just add to that, perfect is not, we don't want that to be the enemy of the good here. We're going for the core. So I think that complements what you're saying there, Vishal. Yeah.
This Mark with the Alliance, and I guess maybe along those lines, if the initial work is to be an aggregate, have you really looked at the cost benefit of dropping down to this level of granularity as opposed to just looking at services that are provided by individuals that have been identified as primary care individuals, whether it's an NP, a primary care physician, whatever?
So I think, if I'm understanding your question correctly, the order of operations with that, tri-sectional is what I'm going to call it, definitional component with the who, what, and where, that has been a point of large discussion amongst the group in terms of, well, yeah, we have this provider list. Why can't we just take those providers and generate from there? So as far as what comes first and how things get subcategorized in the process of actually churning the data, I think that has yet to be fully cemented. But I hear your point, and as far as being efficient about it and not getting too caught up in the weeds, that is something we're trying to avoid and find the best avenue to. So your comments echo what individual committee members have been grappling with already.
Yep.
So to be determined, but we're working through that.
Very good.
Thank you, Mark.
Anyone else? All right. If not, I'll hand it back to you, Vishal. Thank you so much. And
Thank
thanks,
you so
everybody.
much, Jean Marie. Thank you for helping us understand this a little bit more. Next, we have Michael Gillett. Michael will provide us with a presentation on the benchmark, the data collection and reporting piece. Welcome, Michael, to the committee. I'll hand it over to you.
Thanks, Vishal. I don't think I've been with this group for a year, so it's nice to be back with all of you. So I'm going to give you, well, actually, the next slide is going to present an overview of what I'm going to cover. So if someone could advance to the next slide, I'd appreciate it. So I'm going to start by explaining the cost growth benchmark analysis and how it differs from what I'm going to refer to as the cost growth driver analysis. And then I'm going to get into the details of the cost growth benchmark methodology and exactly what's being measured and how it's being measured and why it's being measured the way that it is. I know the prior two presentations you held for questions along the way, but if any of you have questions while I'm speaking, I'm totally comfortable with you raising your hand and indicating you've got the question. Okay, next slide, please. So there are two primary types of analysis. Someone advance the slide. Thanks. Okay, so two primary types of analysis that are quite different. There's the cost growth benchmark analysis, and that's depicted on the left side of this slide. So this is assessing cost growth over the course of 2 years. So, for example, a lot of states in March, April, and May are reporting out their 2021 cost growth. So it's changed from 2020 to 2021. And that's calculated using payer submitted aggregate data. So not claim level, it's aggregate data that's submitted using a standard template with the intention that reporting will be over time at the state level, the region level, the individual insurer level, and the large provider entity level. So this data comes from insurers and from public payers. I want to contrast that with what I'm going to call a cost driver analysis. So this is an attempt to understand at a more detailed level some of the trends that are observed in the aggregate data for assessing whether or not the cost growth benchmark was met. And this requires use of granular data from the all payer claims database. And here we're talking about claims and encounters. The all payer claims database does not capture quite as much data as the benchmark analysis is, but certainly enough data to provide insight into what's driving spending growth in a particular year or over multiple years. So some of the other cost growth benchmark states have performed multiple analyses that look at trends over 5 years, for example. All right, so I'm going to focus on the left side of this slide in my presentation today, talking about the benchmark methodology, but I wanted to make this clarification so that no one's confused about the two different types of analysis. Okay, next slide, please. So when we're assessing performance against the cost growth benchmark, we're measuring total medical expense, and you see that on the left side of the slide. So this is payments for providers' claims for reimbursement for covered services. It also includes non-claims-based payments that might be made to providers, and it includes member cost-sharing obligations, so deductibles, coinsurance, co-payments. You note I said obligation because there's no way of knowing whether members actually made the payments, but we know what the obligation is. So when we measure total medical expense, it's claims and non-claims-based payments to provider organizations plus the member cost-sharing obligation. We add to that something called the net cost of private health insurance. In more plain language, this is private insurer administrative costs plus profit margin for nonprofit contribution to reserves. So together, total medical expense and net cost of private health insurance sums up to total healthcare expenditures. And total healthcare expenditures is what we are measuring at the state level when we are assessing benchmark performance. Okay, next slide, please. So when reporting is done, it's done at 4 levels, as I indicated earlier, but this graphically depicts a little better. So total healthcare expenditures measured at the state level. Then there's separately measurement at the level, the payer level, and the large provider entity level. In most states, when they are reporting at those 3 levels, they're reporting on total medical expense and not for total healthcare expenditures, because the net cost of private health insurance is highly dynamic, because insurer margins go up and down from year to year. If you just look at what happened in 2020 and 2021, big difference in insurer margins those 2 years. So by focusing just on total medical expense, you get a little bit more stability, and you focus on the majority of total healthcare expenditures, which is payments to providers. So at the market level, there's separate reporting on what's happening in the Medicaid market, inclusive of payments to managed care plans and payments made through the healthcare authority and potentially through other agencies for services that are not paid for through MCOs. Then reporting for the Medicare market, both traditional Medicare or Medicare fee-for-service and Medicare Advantage plans. And then finally, the commercial market, inclusive of both self-insured and fully insured. Next level of reporting is at the payer level. So this is Medicaid managed care plans, Medicare Advantage plans, and commercial carriers. And then finally, reporting at the large provider entity level. And this reporting at the provider entity level is by market. So let's say Acme Medical Group serves Medicaid, Medicare, and commercial members. So their reporting on performance against the benchmark would be reported separately for all 3 of those markets, assuming that they have enough attributed lives in each of those markets. And they might have enough in only 1 or 2 of them, not in all 3. Okay, let's talk on the next slide about data sources for doing this measurement. So most of the spending data for assessing benchmark performance. Oh yeah, go ahead.
Michael, just going back to the previous slide, just want to clarify terminology. You've used the term benchmark analysis and then performance against the benchmark. For our purposes, that means the same thing. Now, the board, in developing the benchmark itself, used a methodology to develop the benchmark that is separate from what we're talking about. We're really talking about, and the key is here on this slide, it's performance against the benchmark. So just wanted to clarify that. Thanks.
Yes, right. Performance against the benchmark. So when measuring, thank you, Vishal. When measuring performance against the benchmark, data comes to the healthcare authority primarily from payer-submitted reports. So they are submitting claims and non-claim spending for the 3 markets that we talked about, commercial, Medicare, and Medicaid. They also submit pharmacy rebate information that's used as an offset for spending for pharmacy. And for self-insured plans, they report fees from income of uninsured plans to calculate the net cost of private health insurance. In addition to that information from health plans, data also comes from CMS for fee-for-service claims and Part D spending. There's non-managed care payment data that's included, as I referenced earlier. And then also the states including 3 other sources of public coverage that represent smaller shares of total spending. Health services delivered to individuals served by the Department of Corrections, labor and industries, healthcare spending related to workers' comp, and Federal Veterans Health Administration healthcare spending. And then finally, there are some regulatory reports that are used to extract information for the net cost of private health insurance for insured business. So those are all the data sources that come into the healthcare authority to be analyzed. Next slide, please. So the population that's being assessed for purposes or the population that's being included in these calculations are members who reside within the state and who have at least medical benefit coverage. They might have other coverage, but at least they've got medical benefit coverage. And the payer that's reporting is primary on a claim. When insurers report data to the healthcare authority, they are providing basic information about the insurer. They are providing unadjusted claim spending by service category, and then also non-claim spending by category. When they're providing the claim spending, it's allowed amounts, which means it's inclusive of the member obligation. And they're providing claims data regardless of where the services were delivered. So if someone was visiting their grandmother in Arkansas and they had an ED visit, that's included because it's spending associated with state residents. They're also, as I said, providing pharmacy rebates, member enrollment, because we have to do per capita measurement. Spending analysis for performance against the benchmark is done on a per capita basis. So we need population. And then income from fees of uninsured plans I talked about, and then variance or standard deviation data. And I'll explain a little later how that's used. Next slide. Yeah, Mandy, go ahead.
So I had a question. So you were saying that only members who reside in Washington state, but that you would still include coverage if you were traveling out of state. I mean, I guess what happens here is then we miss college students who are covered under their parents' plan and so that's why, so we
Well,
might.
no, they probably still have residence within the state. Their official residence is probably still within the state.
But so how are you gonna, but their address wouldn't be in the state. So I guess I'm trying to figure out, you're saying reside in the states, you're going by.
Well, they're probably covered under their parents' plan,
Right.
assuming, or you know, whoever's their custodian. So they're probably going to be listed as a dependent on the plan of the custodian or parent or whatever family member they're residing with. And so they will appear, even though they're out of state for college, they'll appear as if they are a state resident.
Yeah, and Mandy, what we're talking about here is the data call, the aggregate data reported by payers directly to HCA. They will not show up in our all payer claims database, you're right. So, and that's where the difference between the cost driver analysis and performance against the benchmark analysis comes in. The data sets are inherently different.
Okay, thank you.
Yeah, thanks for your question. Okay, so when insurers report their spending data and their membership data, they will aggregate it by large provider entity and by insurance type, which is the three markets: commercial, Medicare, Medicaid. And large provider entities are typically organizations that have a lot of primary care clinicians that are employed or otherwise affiliated with them, because spending is attributed to large provider entities through primary care relationships, primarily. And then separately, insurers report spending and membership data for all of their members who are not attributable to a large primary provider entity. Why would they not be attributable? Well, maybe they have a primary care relationship, but it's with a small organization that doesn't meet a size threshold. Or maybe they haven't been to receive primary care anytime recently, so they won't be attributed. And that population of members not attributable is sizable. A couple other considerations: when payers report data, they are asked to report with a run-out period of 180 days. That means there are 6 months after the performance period, which is a calendar year, when claim payments will be made for the prior calendar year, and only after that 6-month period will payers be asked to aggregate their data and prepare it for submission to the healthcare authority. Then finally, there are some individuals who will have some of their benefits not covered by their health plan. This happens most commonly with people with self-insured coverage, where the employer carves out the pharmacy benefit. I'd say this is the most common scenario. In that case, the insurer is asked to make an adjustment to estimate what the carved out benefit value would be based on what the value of that benefit looks like for people who do have the benefit under the health plan.
Michael, just noting time. You have 2 minutes.
Okay. All right, let's go on to the next slide. So these are categories of claims and non-claims-based spending for reporting. On the left, those are, these are categories of covered services just used for broad analysis. And on the right, this is how the insurers report their data. Next slide. There are adjustments made, not at the state and market level, but at the insurer and provider entity levels in order to have confidence in a finding of whether or not an entity met the benchmark. And so that includes risk adjustment by age and sex, truncation of high cost outliers, so you're excluding spending above a threshold, using confidence intervals when reporting, and reporting only those entities that meet a minimum threshold. So the next few slides go into a little bit more detail. So risk adjustment by age and sex, not clinical risk adjustment. The reason for this is work in other states has shown that rising risk scores can't be verified through independent measurement, and there's increasing literature that shows that rising risk scores reflect usually increasing intensity of diagnoses on claims rather than changes in populations. And so all of the cost growth benchmark states across the country now are not using clinical risk adjustment for that reason, because it highly distorts the performance assessment. Next slide. The truncation of high cost outliers is to mute the variation in trend that occurs from year to year, because there might be more high cost individuals one year and fewer the next year. And so we control for that by eliminating spending above a threshold. You can see the threshold here at the bottom of the slide. This creates some statistical stability when assessing performance. Next slide. Confidence intervals, we went too far. Confidence intervals are used to report results so that the public knows, can we be confident whether an organization did or did not meet the benchmark in a given year? So you see here, insurer A's confidence interval crosses the sample benchmark value here of 3.2%. So we would say insurer A, we don't know whether or not they were above or below. Insurer B, we're confident that they were above. Insurer C, we're confident that they were below. So this is just a way of conveying the information so that it's clear how confident we are in the findings. Next slide. And then finally, reporting for insurers and large provider entities is for only those entities that meet a minimum size. The board has not yet made a decision on what the minimum size will be. They're going to consider this question when getting ready to report on 22 performance. You can see on the right a table that includes what have been the minimum thresholds that some of the other states have developed thus far. So this is as yet an unresolved question for reporting at the insurer and provider entity level, but will have to be resolved over the course of the year. And that's it. The last slide just has a resource for you. This is the benchmark data called technical manual. It goes into more detail on everything that I've covered today, if you are interested in understanding the methodology and what payers were asked to submit to the Healthcare Authority.
Thank you, Michael. We are running out of time, but I see Jonathan's hand up. Maybe let's do that one question.
Yeah, Michael, hey, thanks. So even with COVID and what we experienced over the last few years, you haven't seen a difference in the acuity. When we saw services not being offered, I would say it would definitely impact what we've seen over the last few years. And so to discount it, I think is a bit unfair considering what we've gone through.
Yeah, Jonathan, I totally agree that there was a change in acuity in 2020 and 2021. The issue is we don't have a good method for measuring it because the increasing intensity of diagnostic coding on claims creates big distortions so that frankly, we can't tell where there's changes in intensity. And so there's just not a good solution. And doing clinical risk adjustment, there's so much data that indicates that that's not a good approach. So I agree with you. We just haven't found a better way. And so that's why other states are either using HCCTB or no adjustment at all.
Yeah, it's fair, but I guess a good solution isn't just to ignore it and just, I mean, there's got to be a ways to think about it. So I'm hoping this group will consider or at least take recommendations if there are some proposed.
Yeah, so this was discussed by the board. This is an element of the methodology that they adopted. And if you and others can come up with a way of solving this, that would be great. There's no other state that's been able to find a way of doing this that doesn't that solves the problem that I identified.
Thank you, Michael. Thank you, Jonathan. My apologies for cutting this discussion short. I know it's exciting topic and timely, and I'm sure there's a lot more discussion to be had on this. But at this point, I want to thank Michael for presenting to the committee. And moving on to Ross McCool from HCA is going to provide recommended updates to the 2023 benchmark data call. Welcome, Ross. Hand it over to you.
Thank you, Vishal. Hello, everyone. So yes, just want to take a quick moment to update everyone on the 2023 benchmark data call. This coming year, we will take, we're going to request data from calendar years 2020, 2021, and 2022. And then using this data, we'll use the first performance, we'll make our first performance against the benchmark analysis using only data 2021 and 2022. The data from 2020 will be blended into the trend data we received last year to help us better understand a lot of what we were talking about previously with COVID and its effects. But performance will only be looked at for 21 and 22. The submission process will be the same as it was last year, but there will be a couple of updates inside of the submission to make reference categories a little bit more clear for us. Next slide, please. So the first category is that we are adding a way to specify the federal employee health benefits program. The reason being is that there are 2 insurers in the state that cover that, but their coverage is not split down the middle. There are some areas where one insurer covers the hospital claims, but the other insurer covers professional claims. So we wanted to make sure that we weren't double counting members when we are doing the state and market level analysis. We will not be publicly reporting on federal employee benefits alone in the public report. They will just be rolled up into the commercial market. The other change is that we are implementing a way to associate some non-claim spending for insurers and providers without the age sex stratification. We received feedback that this was not doable in some instances, and the trade-off is that the spending won't be age sex risk adjusted. Any questions about these before I move on to the next slide? All right, next slide, please. We will update our materials. So these changes will be mentioned or will be part of the technical manual and submission template update. And we do plan on having a training webinar where we'll cover not only these updates, but also some of the more common errors we saw in submission. And then I have a link to our data call website where these materials will be located once they have been updated. Next slide, please. And then the timeline for the 2023 data call is that we will have a webinar and offer some office hours beginning in either July or early August. And our submissions for this year will be due September 1st. I think that is the last slide in my presentation. Yep, if there are not any questions, I will hand it back to Vishal.
Thank you, Ross. Are there any questions for Ross on this update? If not, I want to go back a couple slides. So Mandy, if you can scroll up just one more. So we're talking about the 8 sex stratification here, kind of linked to Jonathan, what you were asking, Michael, about the clinical risk adjustments. Again, reminding folks that the topic Michael presented was about performance against the benchmark. Aggregate data, provider level, payer level data being reported by payers and issuers. And the closest you can get to a clinical risk adjustment is an indicator on an index that is as high level as a CMI. So it becomes a far from perfect way of adjusting at that high level. When we're talking about clinical risk adjustment, purely based on, especially based on the individual patient risk characteristic, clinical characteristics, that would come into play in the cost driver analysis. And I think that'll be a topic for a different discussion at a later time. So just wanted to clarify that clinical risk adjustment is not discounted completely. It just needs to be applied within the right context and at the right level. Michael, feel free to rebut or correct me.
No rebuttal.
All right, thank you. Thank you, Ross, for sharing the 2023 data call plan with us. Next on deck is Amy Kenner from OnPoint. Welcome, Amy. She'll present on the cost driver study. And I'm going to hand it over to you.
Thanks, Vishal. So I think, we've kind of gone through a bunch of analyses, and I was asked to give kind of a detailed description of the cost driver analysis. And I think Michael did a great job laying out sort of the difference between cost growth driver analysis and the benchmark. And sometimes there's confusion around that, but really what we're looking at is kind of the underlying why or how did cost growth. We're not trying to evaluate, we're not trying to do that sort of benchmark analysis. We're trying to actually drill in and look at, what might have been driving that using the all payer claims database. So I'm going to go through the methods. I have presented this, I think, to this group a little bit more recently than some of the other analyses, and we haven't settled on sort of a phase 2. So the first phase of this was really like setting up how we would look at this, and we haven't sort of started drilling into, okay, we saw hospitals are going up, or we saw outpatients going up, what's really driving that? We haven't gone into that level of detail. So hopefully over the next year or two, we'll start to do a more in-depth analyses of those. But I'll talk about what we have done so far. So next slide, please. So this was what our task was, using the APCD to look at trends and drivers of cost in the healthcare system to inform the Healthcare Cost Transparency Board. So spend and trend by market, geography, health conditions, and demographics, and also looking at potential unintended consequences of cost growth. So those are sort of the tasks that were laid out. And as you can see, some of these can't really be answered by what we're getting from the benchmark data call, right? So things like the health conditions, closer look at demographics, things like that, because it's the other analysis is aggregate data. Next slide, please. So it's really accompanying, this claims data is accompanying the data collected directly from the payers for benchmarking, but it also, as we move forward, we'll have those encounter data and the claims data that will allow us to look at, what's really driving this, what procedures, what detailed categories of care, are there pharmaceuticals, is there shifting of services, intensity of services, are there disparities, things like that. So we've sort of set up this framework that will allow us to drill in deeper going forward. Next slide. So the APCD includes pharmacy, medical, and dental claims for over 5 million patients in Washington. It includes things like PEB and health benefit exchange. It does not include all of the self-insured data, it includes some, but self-insured commercial plans are not required to report data. So that's a data gap we have. We also don't have uninsured. And as of now, we only have Medicare fee-for-service up through 2019. We're hoping to incorporate 2020 and 2021 soon. And alternative payments are not currently reported. Hopefully that will change as we go forward in the future. And long-term care for Medicaid is not reported. Next slide. So, but we do have a lot of data and a lot of claims data, and allows us to look into specific, types of care, procedures, things like that. And so far we have 5 years of data in our analysis, 2017, which aligns with the start of the cost benchmarking period up through 2021. And we attribute claims based on first service date of the claim, and we use 3 months run out or adjudication in the analysis. Next slide. All right, so we have commercial, we have Medicaid, managed care, and then there's fee for service. The fee for service data retrospectively doesn't include line level payments. That has been a challenge. We have Medicare Advantage, Medicare fee for service up through 2019. We have the PEB, we have the benefit exchange, and we have dual eligibles, and we are still kind of trying to figure out how to tackle that. The dual eligible, I know it's across the country, that's something that people are trying to figure out a way to kind of capture the expenditures for dual eligible. So that's something in the future, hopefully we'll be able to incorporate better. Next slide. And we were asked to align the categories of care closely with the benchmarking initiative. So we have the same categories that we saw before. This allows us to, if something's seen in the benchmarking initiative, we'll be able to drill in more deeply using the claims data. Next slide. All right, so geography, we're including Washington residents only. So if folks are living out of state, they are not included in this, even though we do have a lot of out of state patients in the APCD. But if they are Washington residents, we're including the cost of care for both their in-state and out-of-state services. So if they go to California for a service, that would be included. And in the future, we may want to look at that out-of-state growth. By region, when people are assigned to region, that's based on the patient's address. Again, another thing you might want to look at in the future would be, provider address to look at travel and access. And yeah, so out-of-state claims for in-state, that should say in-state residents are included. And the regions that we used were the accountable communities for health and the counties. Next slide. And this shows the ACHs. Next slide. All right, so the age groups were modeled on the age groups used in Washington and in some other states for the benchmarking work, because I think they were aligned with other states. We have had requests to include other groupings in the future. For example, Medicaid coverage doesn't necessarily align with these particular groups, so that might be something to add in the future as well. Next slide. And then we have breakouts by gender. Next slide. And then we also have drill-ins for chronic conditions. So we have we have run sort of flagging of patients based on chronic conditions using CMS's chronic condition warehouse flags logic. And so we're able to look at, what is the cost of a patient with asthma compared to a patient, who doesn't have a chronic condition? What is the cost of a patient with asthma compared to one with diabetes on average? And that will allow us to look into what might be driving trends as well. Next slide. And to try to tackle the really complicated question around potentially unintended consequences, we ran some measures of access and quality, things like, are people being readmitted to the hospital? Are patients getting the screenings that they are supposed to be getting? And starting to look at, at those, because if, obviously we don't want to, stop costs from growing and then have people, not get the care that they need. So that was something that was important to the state to look at. And we've started looking at this. I think this is an area that we'll need to continue to focus on in the future. It's a real challenge to look at the unintended consequences. Next slide. Yep, and so the next few slides are just sort of the metrics that we are using in this preliminary analysis, things like member months and next slide. And looking at the plan paid versus the member paid parts of the payments. Next slide. And then we are looking at 1 year percent changes, percent change from that 2017 baseline. We're looking at percent of behavioral healthcare. We're looking at average allowed amount per service, which is quite a crude measure of price, but allows you to sort of start to see things like that. We looked at high cost members, percent primary care using the OFM definition of primary care, and so forth. So next slide, please. And of course, PMPMs and utilization, sort of looking at rates of utilization. So, and I think that might be the end of it. Next slide. Yeah, so then just, restating some of the limitations. We don't have the self-insured or uninsured, and we're hoping to incorporate more Medicare and Medicaid fee-for-service data in the future and alternative payments. So next slide. Yep, so that's the basic gist of the benchmarking analysis where, I think we're pretty much wrapped up with phase 1, hoping that as we go forward, we'll have more, I think there are more questions than answers, and hopefully we'll continue to sort of dig into the data and look at, more of the nitty-gritty of what might be actually underlying some of these trends that we're seeing. So. And thank you for letting me speak to you today.
Thank you, Amy. As I open this up to the committee members for questions, just one thing, if you could clarify, a couple slides back, one of your metrics is around primary care spending.
Yep.
And you mentioned that we're using, our on point has used a definition that was developed by OFM and then used again by HCA for its report. As the primary care advisory group and committee comes up with its recommendations, just like Jean Marie was presenting, what is the path forward, or have you guys talked about how to incorporate that in going forward, and what does that do to your cost drivers analysis approach?
Yeah, so that's something that we would love, we'd love to be more involved with and incorporate as we go forward. And I think the benchmark itself is using the prior definition. So I'm guessing that as you go forward, you would update that as well. So yeah, so happy. I probably would love to reach out to Jean Marie and start talking about, what they're doing and how we can incorporate that here as we go.
That'd be great, Amy. I was going to say, let's connect, because I think that would be really good to stay in tandem on that.
Yep. Sounds good.
Perfect.
Thank you. Thank you both. All right, opening it up to the committee for Again, questions, thoughts, concerns, guidance?
So there is a tremendous amount of overlap between the OFM definition and the one the primary care committee is coming up with. So I think even with some changes in the future with that definition, I don't see it really altering the cost piece like that much. I mean, there's a lot of overlap between the two.
That is encouraging to hear, Mandy. Any other questions from members or Amy or on this topic?
I might have missed it. What years are you using for this?
Yeah, so we used 2017 through 2019.
All right,
I mean,
there.
through 2021, Mandy. Yeah.
Jonathan, I saw you came off mute. Did you have a thought you wanted to share?
I've got I think a larger question. And this is more or less maybe for HCA to kind of paint the picture of how each of these are going to be used from, the initial work that John and Tom has done, identifying outliers, how is that report going to be used? And then just trying to get a better sense of the work from the cost benchmarking standpoint, and then this supplemental stuff that will help shed it. I'm seeking the bigger picture, and hopefully you can help paint that.
That is a great question. And at the risk of winging it, well, actually, let me just say this. How about we note that question, Mandy Weeks-Green, and we tee that up for the next committee meeting? Because Jonathan, you're right. I think there is a method of the madness, and it would be good to be able to articulate that and paint the picture to say, how do these different puzzle pieces fit together in informing the overall approach for the board in its work, and how are we supporting the conversations that board members want to have? Is that a fair way to put it? Is that where you were headed?
Sure. Yeah. We'd love to have conversations around that and just better understand it, because I mean, if we have kind of the shared vision, I think it's easier for us to be more engaged and hopefully help contribute and push back where needed.
Absolutely. No, great question. Yeah, let's tee it up, and I think it'd be a good fruitful discussion for this advisory committee to have. In the meantime, thank you, Amy. Thank you for presenting the cost drivers analysis methodology and approach. We did rush through some of Michael's slides towards the end. Michael, my apologies for rushing you through that. And if there are questions that committee members wanted to ask or share comments about the content that Michael shared, I will open it up now.
Shaw, this is Jonathan. I mean, not so much on the Michael piece, even though, I mean, the part of it is, yeah, this work is challenging and difficult, and just because it's challenging and difficult doesn't mean we shouldn't be addressing it. But on these various pieces that are in play here, where we can have kind of the standardized approach and methodology going into it, I think it makes it easier going from one to the next. So using the same truncation measures, seeing the, I mean, outlier aspects, going from analysis to analysis and having that same common themes, I think is going to be important, because some use certain pieces, others use different pieces, and having a more standardized approach, I think, will benefit all.
That is a good point. Thank you, Jonathan. Other comments and thoughts from committee members? I am not hearing anything. So Thank you again. Thank you to everyone for attending today. Like Mandy mentioned earlier, the recording and summary of this meeting will be posted shortly on the HCA website. Thank you again to our presenters and for allowing us the opportunity to ask questions and gain clarity. The next meeting for this advisory committee will be on June 6th at 2 p.m. Pacific. And I look forward to seeing you guys at the next meeting. Thank you. Have a good afternoon.
Thank you. Bye-bye.
Thanks.